CataractCoach.com, Enhanced Ectasia, Black Box Thinking. This is a video from the Cataract Coach Podcast number 66 from yesterday.
This video illustrates the philosophy of black box thinking. Drawn from aviation, the growing mindset of learning from failures refers to the excruciating investigation of the data available to understand the root causes of complications, to design processes to avoid recurrences. Ectasia emerged as a severe but rare complication of keratorefractive procedures. Its incidence has reduced due to the significant advances in corneal diagnostics and an enhanced understanding of its pathophysiology. Ectasia risk assessment goes beyond detecting mild subclinical or fruste keratoconus. In addition to front surface topography, characterizing corneal properties through multimodal diagnostics can quantify the predisposition or susceptibility of the cornea for biomechanical failure and ectasia progression. Considering the impact of the refractive procedure on the cornea, along with such properties, is paramount. The lessons learned from a case of iatrogenic keratectasia after small incision lenticule extraction and its management with a combination of intracorneal ring segment implantation associated with epi-on cross-linking. In October 2014, a 26-year-old woman intolerant to contact lenses presented with an interest in refractive surgery to correct relatively high myopia. Unremarkable slit lamp biomicroscopy and fundoscopy were observed in both eyes, with front normal surface topography revealing a symmetric bow tie in both eyes. Central corneal thickness was 520 microns in the right eye and 522 microns in the left eye. The Dr Ambrosio enhanced ectasia display demonstrated normal elevation maps for both eyes and a bad D of 1.27 in the right eye and 1.07 in the left. Artmax was 359 and 352 microns in the right and left eyes, respectively. Smile Lex was considered the most suitable procedure at that time, considering its biomechanical advantage over LASIK, the correction level, the patient's age, and the available corneal imaging data. The residual stromal bed, or RSB, was higher than 250 microns. We used optimized Visumax energy settings and the two-hand technique described by Dan Reinstein. Surgery was uneventful and the patient did well, presenting with uncorrected visual acuity of 20/20 in both eyes 6 days after Smile. She returned with no complaints for regular follow-ups at 1 month, 6 months, 1 year, and 2 years after the procedure when a dilated fundus exam was performed. However, 4 years after Smile, the patient returned complaining of vision deterioration in the right eye. Her UDVA was 2100, corrected to 20/25 minus with high cylinder. Pentacam OD confirmed the diagnosis of corneal ectasia. The left eye had an uncorrected vision of 20/25, corrected to 20/20 with a low correction. The OCT, 4 years after Smile, demonstrated a thicker epithelium in the center, corroborating a stable, non-ectatic pattern as seen on corneal tomography in the left eye. This pattern contrasted with the epithelial thinning in the right eye, consistent with progressive ectasia. The management of iatrogenic ectasia starts with empathic patient counseling. The patient admitted several allergic episodes and eye rubbing over the year before she noticed decreased vision in her right eye. Clinical treatment included an emphatic directive to avoid eye rubbing, along with ocular surface optimization and allergy treatment. Oral supplementation with omega-3, essential fatty acids, and riboflavin for promoting natural cross-linking, along with topical olopatadine and preservative-free artificial tears. No surgery was indicated for the left eye, but a close follow-up. The therapeutic procedure in the right eye involved a femtosecond-assisted intracorneal ring segment implantation. Manual dissection was necessary to implant one Kera ring segment. This was associated with epi-on cross-linking using a dextran-free riboflavin 0.15% solution with HPMC injected in the tunnel. This technique was adapted from Seiler's original work of cross-linking with intrastromal injection in femtosecond-created channels. The 9 milliwatts per centimeter squared UVA irradiation was used for 10 minutes. 8 months after the therapeutic surgery in the right eye, UDVA was improved to 2050, corrected to 2025. Significant corneal flattening and regularization were observed, along with a mild increase in backward scattering on Scheimpflug densitometry and OCT. The patient was relatively happy with the result for years after the therapeutic procedure. Her UDVA was 2060 in the right eye and 2020 in the left eye. DCVA was 2020 in the right eye and 2015 in the left eye. The curvature map was stable, with no change in posterior elevation in the left eye. The CBI post-LVC was 0.00, demonstrating stability on the tomography and biomechanical assessments, which were in agreement with the Hamburg-Eastanging longitudinal biomechanical assessment that demonstrates the positive effect of clinical treatment, including oral riboflavin and no eye rubbing. The black box thinking is a growing mindset in which we learn from revisiting failures. 2 years after surgery, mild ectatic progression could have been detected by corneal tomography despite good vision in the right eye. This could have led to a proactive clinical treatment, possibly preventing ectasia progression. The second and most remarkable lesson is related to ectasia risk assessment, which should consider the classic two-hit hypothesis. The inherent patient predisposition and the impact of the environment determine biomechanical stability or ectasia progression. The preoperative Pentacam highlighted an artmax lower than 390 microns in both eyes. Also, the Pentacam random forest index was 0.22 in the right eye and 0.19 in the left eye, higher than the optimized cutoff of 0.15. This AI function was developed in 2016 as the Tomography and Biomechanical Index from Scheimpflug Tomography and Biomechanics, which was retrospectively calculated as 0.72 in the right eye and 0.25 in the left. Also, the OCT segmental or layered tomography pre-op demonstrated a relatively thinner epithelium inferiorly. These data corroborate the demonstration of a high susceptibility for ectasia before SMILE. The relational tissue altered, a novel AI function that calculates the impact from laser vision correction, would be too high. A phakic IOL would be the procedure of choice. Multimodal diagnostics generates an overwhelming amount of clinical information. Artificial intelligence enables multidimensional analysis, providing enhanced ectasia susceptibility detection before refractive surgery and alerting the surgeon of risks in real time. The algorithm A2I squared refers to the application of artificial intelligence, the hows, considering the application of ancient philosophy, the why. This is fundamental to analyzing the plethora of clinical data available efficiently. The BRAIN, or Brazilian Artificial Intelligence Networking in Medicine software, provides an external software solution that integrates data from Pentacam and Corviz regarding the structure of the cornea. This is combined with the impact of the corneal procedure through the relational tissue altered to establish an objective ectasia susceptibility score. The conscious application of AI tools with the black box thinking mindset allows us to optimize refractive surgery decisions. This personalized approach ensures enhanced accuracy for assessing ectasia risk and may empower surgeons to transform refractive surgery, enhancing precision, minimizing risks, and revolutionizing patient care. Thank you for your kind attention.